Good evening. Thank you for joining us for a Rural EMS and COVID-19 Information and Discussion Facebook Live event. This event is being hosted by Simulation Motion Nebraska with support from the University of Nebraska Medical Center, the Nebraska Medicine, and the IXL program of UNMC. My name is Doug Decker, and I'm the program manager for Simulation Motion Nebraska, and I will be your moderator tonight. Tonight's event will start with 2 short videos demonstrating the donning and doffing of proper PPE to wear when emergency medical services members working on ambulances come in contact with a patient who has suspected of having or has COVID-19. These videos are intended as an overview of the donning and doffing process and do not represent the complete training session in the procedure. As a reminder, proper use of an N95 mask consists of also getting fit tested. The video will be followed by a panel discussion, and I will introduce our panel following the videos.
Today we're going to be discussing N95 Level PPE when caring for COVID-19 patients. When you're beginning your process, you want to make sure you have all of your appropriate PPE ready. That being a yellow disposable gown, your proper fit tested N95 mask, your facial shield, and patient care gloves. You also want to ensure that you remove any jewelry that could impede your PPE, as well as tie your hair back. When you are beginning your donning process, you always want to start with hand hygiene. Hand hygiene should be done for a minimum of 20 seconds, most likely longer. Your hands need to be completely dry before you are complete with that hand washing process. You want to ensure you have very good friction and are getting each finger individually. Once you have completed your hand hygiene, you want to apply your disposable gown. You may need to have a donning buddy assist you at tying knots on the back. Once you have appropriately donned your gown, you're going to move on to your N95 face mask. When you're applying your N95 face mask, you want to ensure you are putting the bottom band on first because this helps you get an adequate seal. The first band is at the base of the neck, and the second band goes at the crown of the head. Once you have it on, you want to do your seal check. When you're completing a seal check, you want to first make sure you're only molding the mask to your nose. You do not want to pinch because this may cause an air leak. Once you have adequately molded the mask to your nose, you're going to apply gentle pressure to the front of the mask, inhale, and then exhale gently. You should feel a pressure buildup under the face mask, and you should not feel any air leaking up into your eyes or any fogging of glasses or face shields. Once you have completed your seal check, you want to don your face mask. Once your face mask has been applied, you want to apply patient care gloves. You want to make sure that the cuff of the gloves is going over the cuff of the gown. After you have donned all of your PPE, you just want to do one last safety check to make sure you haven't forgotten anything and none of your PPE is damaged. Once your safety check is complete, you can enter your patient's room. When you have completed your cares with your patient and you're preparing to doff out of the room, you want to begin with putting hand sanitizer on top of your patient care gloves. Again, making sure that you are completing this hand hygiene for a minimum of 20 seconds, but most likely longer, with adequate friction in each finger individually. Next, you're going to take off your gown. By doing this, you're going to lean forward, cross your arms, and pop the tabs as you roll the gown into itself.
Hey Doug, I just got a text from the EMS crew.
When you are throwing your gown away, you want to make sure you're not pushing anything down into the trash can to prevent any aerosolization of any bacteria. Next, you'll remove your gloves using the glove and glove technique. After removing your gloves, complete hand hygiene, again for a minimum of 20 seconds. When you have completed hand hygiene, gently lean forward and remove your face mask. And drop it straight into the trash can. At this point in time, you would exit the patient room, and immediately in the hallway, you would complete hand hygiene again. After completing your hand hygiene, you are now ready to remove your N95 mask. You always want to start with the band that is at the base of your neck. Gently lean forward and lift the band over your head and allow it to dangle, taking care not to touch the front of the mask. Then you will remove the band at the crown of your head and allow your face mask to fall forward into the trash can. You would then complete hand hygiene again, and you could exit the area. And that completes the donning and doffing process.
I'd like to go ahead and introduce to you our panel tonight. First person I'd like to introduce to my right, at least 6 feet away, is Dr. John Lowe. Dr. Lowe is the Assistant Vice Chancellor for Interprofessional Health Security Training and Education, and Associate Professor of Environment, Agriculture, and Occupational Health with the UNMC College of Public Health. He's also Director of Research for the Biocontainment Unit here at UNMC. To my far right is Dr. Eric Ernest, Medical Director for the State of Nebraska EMS Board, Emergency Department Staff Physician for Nebraska Medicine, Assistant Professor with the UNMC Department of Emergency Medicine. He's also the Medical Director for several urban and rural EMS agencies. In the event invite that you all saw, there was supposed to be a third panelist tonight. That was Mr. Kalen Wright, who was just in the videos you watched. He is a Nursing Professional Development Specialist with Nebraska Medicine and was scheduled to be a part of the panel, but will not be able to join us tonight. A situation at work prevented him from being able to be here in time to attend in person. I believe he will be on the Facebook feed, though, monitoring us live. As those of us in EMS know, doesn't matter what you are doing, whether it's a birthday or whatever, when the time comes you can't go to the birthday party or whatever, you can't go. And Mr. Knight had to tap out for work commitments. During the panelist discussion tonight, feel free to type in your EMS-based COVID-19 questions into the feed. We will continue to monitor the feed as the panelists are speaking. After the panel is finished, their discussion, your questions will be addressed. Prior to this event, we received some questions via email. I'll do of those first prior to taking questions from the live feed. With the number of people that we have on the live stream right now, we will most likely not be able to answer all of your questions during this particular event. After the broadcast, Sim Nebraska will work to answer all of your questions. We will post a Q&A document on our Facebook page and our website as soon as we can. And now I'd like to give it over to Dr. Lowe.
Thanks, Doug. Well, thanks everybody for tuning in tonight. I'm just going to go ahead and give a quick high-level update on kind of the state of events related to the novel coronavirus, or as we'll probably be referring to, COVID-19 or SARS coronavirus 2. So just kind of a state of things as they exist today. We've come right up on 500,000 cases worldwide, with China bearing the majority of those cases, 81,000 cases to date in China. With Italy, 69,000 cases, Spain, 39,000 cases, and the U.S. now coming in at 51,000 cases, really most of those just in the last few weeks here. Of note, a few things. New York now has 30,000 cases and accounts for roughly 5% of the cases worldwide. And then we also have kind of a unique event in Louisiana, as we have just come out of Mardi Gras, which was in full effect this year. they've experienced the identification of 1,500 cases since Monday. So as you can imagine, I'm sure many of you are experiencing, and we saw some of the questions that were sent in ahead of time. This is creating unique situations across the country and across our state in terms of shortages of supplies, rapid response to escalation of cases presenting to the medical system, and just kind of planning for things that we've talked about for years in terms of pandemic planning and actually changing and putting those into practice. So I think some of the things that we'll discuss tonight as we get into the Q&A and a number of other items that are really hot topics nationwide right now are what are appropriate strategies for personal protective equipment, especially in the mixed environments that EMS in Nebraska respond to. What are possible strategies to reuse personal protective equipment or extend the use of personal protective equipment? These are issues that we're being overwhelmed by right now with questions across the nation and across Nebraska. So we want to get in and talk about some of that as well. So I think with that, I'll turn it back to you, Doug.
Okay, thank you very much for that overview. And then we're going to go ahead and give Dr. Ernest a few minutes to go ahead and speak, and then we'll start taking your questions.
Wonderful. Thank you, Doug, and welcome everyone to the live event tonight. As Doug said, my name is Eric Ernest. I serve as the State EMS Medical Director for the state of Nebraska. And I'm honored to come and speak to you guys tonight to try to update you on a situation that is very unique. This is something that is quite frankly unprecedented, not only within our state of Nebraska, but also within the United States and the world. And this is starting to hit closer and closer to home, as I'm sure you're all well aware, the escalating number of cases locally within the state of Nebraska, and obviously with EMS being on the front line of the fight against this pandemic, that there are many questions and many things that we don't commonly come across and that we need to consider when it comes to training and preparedness that, like I said, many of us have never had to deal with and may never have to deal with again. But we'll do our best here tonight to try to answer some of those questions and get through it. So I would like to point everyone to a wonderful resource that we're trying to put together on the Department of Health and Human Services website. If you go to DHHS and the EMS side of things, there's a direct link there for COVID preparations. On that website, you'll find a number of resources, including links to CDC documents as they pertain to EMS preparedness. You'll also find a state protocol that was put together to try to help agencies navigate through this that will apply both at the EMT or basic level all the way up through the ALS and paramedic agencies. Also on that website is guidance when it comes to working with your 911 dispatch centers to try to help and identify these patients even prior to EMS's arrival on scene to try to help give us a little bit of extra time and preparation to adequately prepare and don appropriate personal protective equipment. So walking through the process a little bit, and I'm sure a lot of this will come out in the questions, but giving kind of a high-level overview in kind of the way we would hope that this would transpire when it comes to these patients. And granted, there will be more and more of these patients coming into the EMS fray as time goes on and as people start to develop this disease. But hopefully the initial screen does start at dispatch. Hopefully you can work with your local 911 center and advocate with them to try to implement some kind of screening where any call for medical service is met with a screening tool, and that is on the DHHS website. So that you can have them screen the caller if there's symptoms that are consistent with COVID, that can be relayed to the first responders, and that appropriate PPE can be donned even before making contact with the patient in their residence or place of business. After getting on scene, the idea being to try to limit the number of people that are coming in contact with a potential patient. The concept, and hopefully you've been hearing on this on the news and other places, that the idea of social distancing or social separation is highly important. We know that approximately 6 feet or greater is a good, safe distance to be away from someone who's exhibiting symptoms. And so limiting the number of providers that are within what I would call the kind of that danger zone of risk of infection is important. So having someone, maybe a single provider, having fully donned their personal protective equipment and making that initial contact with the patient to try to ascertain whether or not this is truly a concern for COVID or maybe some other pathology. It should be known that these symptoms that are with COVID are they overlap with a lot of other things like influenza, other viral illnesses, bacterial pneumonia, things of that nature. So you have to kind of cast a broad net and be very suspicious of this. And if you have to err on the side of caution, go ahead and make sure that you're in full PPE. Once you make contact and you determine that this patient may be a consideration for COVID precautions, again, limiting the number of providers, if you can have the patient walk out of their residence or place of business if they're able to do so, and really, again, limiting the number of people that are interacting with that patient. And then providing treatment as usual. The considerations for that is really when we look at aerosolizing producing procedures, things like nebulizers, non-rebreather masks, bag valve masks, intubation, or CPAP. All of those are putting both the general public, the crew, the apparatus, equipment, things of that nature at a high risk for contamination. So trying to minimize those types of procedures at all possible. We'll get into some of the details of that. And there's also more information on the website and with CDC as to how to get through that. So, and then obviously delivering the patient to the hospital, working with your local hospital to figure out doffing procedures as to how to take off your PPE, that you're not exposing the emergency department staff, other patients within the emergency department. So all these concepts in kind of a high-level overview are very important for the safe delivery of these patients from the community to your local emergency department.
Okay. Thank you, Dr. Ernest. And we're going to go ahead and take some of the questions that we received prior to the event. And please go ahead and still keep putting in your questions as you have them come up, and we will continue to answer them. Again, understanding that we may not get to everyone's question tonight, but we will try and do the best we can to get a Q&A form up on our website or up on Facebook here as soon as we can with the answers to the questions we didn't get to tonight. So, Dr. Ernest, you're first.
Wonderful.
First question tonight is, can we refuse transport of patients with suspected COVID-19?
So this is an interesting question. So obviously any call for service has certain legal ramifications that if you were to outright refuse a patient for service, that you could run into some trouble there. We are in the process of drafting and hopefully within the next couple days putting out a EMS protocol or guideline that will deal with the non-transport of a COVID patient, especially when this becomes more prevalent, so that we could safely advocate that a patient may stay in their own home and not be putting other people in the public at risk or the ER at risk. So outright refusal, probably not, but going through a certain set of criteria based on age, physical exam findings, vital signs, things of that nature, where if everything is looking kind of like a minimal symptom COVID patient that could be safely monitored at home, and being able to advocate for that and then providing resources to that patient to be able to stay at home and then contact a healthcare professional if their symptoms worsen or call 911 back. We are currently working on that, and hopefully we'll have that up within the next couple of days of a non-transport policy. So hopefully that answers that question.
Okay, thank you. The next question I have is for you, Dr. Lowe. EMS professionals around the state are sharing a Facebook story that drinking hot liquid will kill the virus. Can you speak to that?
Yeah, so I would say that that is a false statement. You know, perhaps it might help ease some of the symptoms of sore throat or something like that, but it's really not going to have any impact on an infection or the likelihood that you would or would not get an infection.
Okay, thank you. And we're going to come right back to you again, but I think there may be some backup from Dr. Ernest on this one. For EMS and fire departments without fit-tested masks, the N95s, what is appropriate to use for a mask?
Yeah, so it's important to know that with an N95, if you don't have an appropriately fit-tested model of N95, then the N95 is going to perform pretty much the same as a procedure mask or a surgical mask. So we recommend using the procedure mask or surgical mask, a thing that if you don't have the ability to have fit testing and be matched up with the appropriate N95, one strategy is to put a procedure mask on a patient. So studies are very definitive that putting a procedure mask on a patient drastically reduces the amount of droplets and aerosols that are generated by an individual patient. So that's generally the best practice. Myself, we have 1870 plus is what we use broadly in our healthcare system. I'm one of the lucky few that can't get a fit test to that, so I have a different N95 assigned to me. And I would not be able to wear an 1870 and get the 95% filtration protection that an N95 affords.
Dr. Nerse, I think you had some comments about the aerosolized potential procedures that we do in EMS.
Yeah, and I would re-echo what Dr. Lowe had mentioned in regards to if you don't have access to N95s, which currently is a issue statewide and across the nation in terms of getting access to that, that if you are looking to try a fit test, contacting a local health department is usually the best first step, that they usually have access or know where to get access to fit testing equipment. And if you can arrange that and able to get supplies in, that's great. But if not, then a simple surgical mask on the patient as well as on a provider is probably the next best thing. Again, the biggest risk comes with those aerosol producing procedures that I just mentioned, and really trying to minimize those at all costs. If for some reason that you did need to produce or have one of those done, let's say offer a nebulizer of albuterol to a patient that was wheezing, either doing that within the patient's home or doing it outside, or if they're in the back of the ambulance, stopping and actually opening the doors, using the exhaust vents, things of that nature, to create as much negative airflow or exchange of air over a certain period of time to minimize the aerosolization that's kind of within the air of the back of the ambulance. So those are some strategies that you can use to try to, again, stay safe.
Yeah, and I think just to add to that, in terms of aerosol generating procedures, so we've cared for a fair number of COVID cases here at UNMC, and we've done a fair amount of aerosol and environmental testing. And one of the things that we've identified is that moderate to high flow nasal cannula oxygen delivery is one of the things that can generate aerosols with this. So that's another thing to keep in mind when working through, is there an aerosol risk for this patient encounter or not?
Okay, thank you, gentlemen. Dr. Nerse, we're going to come back to you. If EMS or fire departments don't have gowns or run out of gowns and departments need to use bunker gear as protection, what's the appropriate way to clean or disinfect that gear?
Sure. So just like any exposure, whether it be biologic or some kind of environmental hazard, as is commonly encountered within the fire service, certainly washing those per manufacturer recommendation. A lot of departments will use some kind of extractor device with a soap and water type solution, as well as chemical extraction, and putting the bunker gear through that process should take care of any residual virus that may be on that clothing. But to be mindful that taking certain precautions, that if you don't have access to gowns, whether disposable or reusable, to try to protect yourself in some way. Bunker gear is a great backup option. If none of that is available as well, certainly changing your clothes or trying to get scrubs or something of that nature from the hospital once you're done with patient care, to again not bringing that back to the station, to your home, etc., and minimizing exposure to those around you.
Okay, thank you. And Dr. Lowe, the question for you would be, how do squads make sure that they dispose of all contaminated PPE correctly?
Yeah, so that's a great question, and one that we've gotten quite a bit. You know, early on in this outbreak, there was a lot of uncertainty about how waste related to patient encounters with COVID patients needed to be handled. So CDC has been very definitive on this, that any waste or trash that's generated from COVID patient encounters can go into the typical municipal waste stream. The one caveat is the same caveat that applies to all medical waste or biohazard waste that comes out of healthcare, which is, does it pose a spill risk or splash risk? If the answer to that is yes, then it needs to be handled as biohazardous waste or medical waste. Just to piggyback on one of the things that was just said earlier, if you are in an encounter or environment where all you have is respiratory protection, and so you're going in clothing that you would wear home or that you'd wear to any other aspect of your job, just laundering that clothing is going to be completely effective against coronavirus as long as you're using soap and water. This is a virus that's not incredibly stable and is relatively easy to inactivate through cleaning. So soap and water, super effective. We've done a number of calls where we've had EMS personnel go into a house or do a full patient encounter and find out after the fact that this individual was COVID positive. So they did not have the ability to don the full gown and mask. And our advice to them was to launder that clothing before, going back to their, their shop or back home.
Okay, thank you. Dr. Ernest, while en route to a 911 call, what questions should EMTs be asking their dispatch center concerning the possible coronavirus patient?
Sure, so this is a great question. Something that I would definitely advocate for all EMS agencies to look at, especially during this pandemic phase, is really going back to your local dispatch center. I realize that a lot of folks who are operating within the volunteer realm are often dependent on a sheriff's office-based dispatch center, which may or may not have emergency medical dispatch capabilities. But even that still, there are some simple questions that the dispatcher can ask even before dispatching a unit. And so if you reference the DHHS website, there is a algorithm that a dispatcher could use that's pretty straightforward and simple that could use to help screen those patients. And then hopefully the dispatcher is notifying the responding units that this patient may be at risk or not. But I would also encourage, if that information is not being provided by dispatch, either they got busy, they didn't ask the question, that really trying to create a culture within EMS, especially during this pandemic phase, that we are really assuming almost every patient could be a possible COVID patient, and to really inquire about those symptoms like cough, shortness of breath, fever, body aches, things of that nature on every patient encounter. We've been tricked a little bit in the emergency department on patients that would otherwise present for things that you wouldn't think were COVID related, let's say a fall. And after you ask a few questions, realizing, well, the fall came because the patient was dizzy, and the reason they were dizzy is because they had a fever, and the reason they had a fever is because they just got back from a trip, say, to Seattle. And so some of those things that kind of transpire with a couple questions can quickly reveal that this patient may be at risk. So despite whatever dispatch says and the information they have, treating every patient right now as a potential, asking some basic questions even on things that are not related to viral URI type symptoms, and just to make sure that that patient's not exhibiting any of those, to make sure that you're providing enough protection for yourself and your crews.
Okay, thank you. And for either one of you, I'm pretty sure I know the answer to this question, but initial assessment should begin from a distance of how many feet from the patient if possible in an EMS situation?
So I think what we're advocating for now and what CDC is currently recommending is a minimum of 6 feet. And making sure that if the opportunity presents, making sure that PPE is on the patient, or excuse me, on you first. And then as Dr. Lowe had mentioned, trying to get a simple face mask on the patient as quickly as possible to try to cut down on a transmission risk before introducing any other personnel into that scene.
Okay. Anything else, Dr. Lowe, with that?
No, that was a great answer.
Okay. Got the right guy in that chair then, that's what you're saying. All right. Again, back to you, Dr. Ernst, and I think you touched on this a little bit, but just to kind of clarify, how do you apply oxygen to a patient wearing a face mask?
So this is a great question. So obviously this is a respiratory illness, and so the risk, especially people who are older or who have structural lung disease at baseline, COPD, emphysema, things of that nature, are probably going to need and require oxygen. Simple is better. I think we were all kind of taught kind of the escalating approach of oxygen therapy in either EMT or paramedic school, that if we can get away with a low flow nasal cannula, and we would place that underneath the mask, again, so if the patient is coughing or sneezing, things of that nature, that mask is catching those respiratory droplets, and applying as little of oxygen as possible to get the clinical effects. So not slapping a non-rebreather on the patient and cranking it up to 15 liters a minute, maybe starting out with a nasal cannula, 2 to 4 liters per minute, to see if you can get a clinical effect. And if the patient is stabilized from that, they may not have a perfect oxygen saturation, but say they're in the low 90s and they're more comfortable, less is more in these situations. And so trying to apply as minimal as possible to get the clinical effect, and making sure that things like a nasal cannula is underneath the mask. If you have to escalate to non-rebreather, CPAP, things of that nature, obviously, if you have access or the ability to get filtering equipment, which right now is in unfortunately very short supply, there are filters that can be placed on the end of a bag valve mask on the exhalation port, also on CPAP devices that will filter out the virus. But again, getting access to some of those materials right now is incredibly difficult. So if you get them, great. If not, try to minimize those as much as possible.
I just want to piggyback off one thing. We can see some of the chat going off onto our right here, and I see Kaylin Knight was highlighting the distinction between a fit test and a seal check. So a couple important things to highlight, as we just talked about the importance and value of having a fit tested N95 that you know is your match and your fit. So we did see suspension of the normal kind of standard operating procedure and guidelines from our federal partners, where typically you have to be fit tested annually. And recently, just in an effort to save the supply, because when you're fit tested, you generally have to use N95s as part of that fit test. If you've been fit tested in the last over year prior and you haven't had any major physiological changes, you can go ahead and continue to use that same N95 that you were fit tested on the previous year without being re-fit tested. When we talk about fit test, that generally means one of two things. There's a fit test where you kind of have a bag on your head, and then we release vapor and test it that way. The other is a quantitative fit test where we're actually counting particles that are passing through the filter into the exposure chamber. Seal check, on the other hand, is what you do with your fit tested N95 every time that you put on an N95 to make sure that you have seated the mask appropriately on your face and that you have a good fit so that that mask on that particular time that you're wearing it is going to protect you.
Thank you for that clarification. We've got just two more quick questions, and we're going to go ahead and move to the questions that have been coming in online here. So the next one, this will be for both of you gentlemen. Person states, I just attended a webinar on COVID-19, and they said that in the EMS field, that the N95 is overkill for PPE and surgical masks are just as efficient at keeping us safe, and a mask on the patient with ambulance patient compartment exhaust fan on high does more than keeping the transmission controlled than using an N95. Any thoughts on that?
Can you run through that question?
Yeah, that was kind of a long one, wasn't it? I'm sorry. So basically, they're saying that the information they received was that, as far as EMS providers are concerned in the field, that an N95 is overkill when you're in the back of the ambulance, and that just a surgical mask is fine as long as they have we've got an exhaust fan in there that will draw air from the front of the truck out through the back and help keep that circulation going. So,
yeah, so I think there's two things that we're navigating right now. One of those things is availability of resources, and the other is what are appropriate measures should we run out of the available resources that fit. So CDC guidance is pretty clear on this. WHO just changed their guidance that personal protective equipment precautions should be airborne. So that's N95 or above. Many of you are probably familiar with powered air purifying respirators as well. We don't deploy those frequently in EMS realm, but so for airborne precautions, the recommendations are clear in N95. CDC has taken a very prudent move in my mind in saying that if we run out of N95s or if your service runs out of N95s or you're not fit tested, then the appropriate thing to do is to use a procedure mask. And again, stressing that procedure masks on patients do a lot to knock down the risk. I think that you are all familiar with how confined a space the back of the ambulance is, and it's pretty easy to connect the dots that this is an aerosol transmitted disease in a confined space, and we just don't have the airflow for really firm unidirectional flow through the back of an ambulance. So I would strongly recommend following CDC guidelines on using an N95 if available, and if not available, using the next best measure, which is procedure mask on patient and provider.
okay.
One additional thing that I would add, and this is again a benefit of the fire service, and this is not, you're not going to find this in any CDC or national or international guidelines, but realizing that in these times that if you are out of PPE and you do say need to do one of these aerosol producing procedures, that most fire departments have fit tested their members with SCBAs. And so the ability to go on air for patient treatment, if you absolutely needed to, would be another way to protect yourself. Again, you won't find this in much of the national guidance just because it's more geared towards healthcare. But given the unique scenario of a fire service that already may be fit tested to an SCBA respirator, that could be a backup option should you not have availability of PPE.
Okay, thank you. Last question is kind of a two-part here, and then we'll start moving to the ones that we've been receiving online. Dr. Loso, are we seeing any evolutions in the virus?
So I think that that's something that we're weary of and that we're trying to keep a close eye on. So the way RNA viruses work, they generally make mutations on a certain frequency that with the number of times the virus replicates in an individual. So it's something that we're watching. We hear lots of anecdotes about, oh, the virus is doing something different now, it's transmitting differently, or the infections are starting to look different. Right now I would say that that is just that, anecdotes or stories. We haven't seen anything confirmed. But of course, the longer the virus is in a really large population and continuing to circulate, we're always watching for, are the reports that we heard early starting to shift to where we're starting to see other groups of people be identified as high risk for serious complications. So far, we haven't seen that, although, you know, of course, the more people that are infected, the more individual cases there are of outliers. So to date, we haven't seen any major shifts in either how the virus transmits or the disease it's causing, but it is something that we're keeping a close eye on.
Okay, thank you. And then as kind of a follow-up, do we have any evidence of immunity after infection yet?
So another great question. That's something that we would anticipate and expect to happen, although this is a novel virus and we're still learning a lot about it. So to be quite frank, we just don't have that information yet. There are a few case reports, mainly out of China and a few other countries where there is reported reinfection. It's really difficult to know if those are people that were ill and started to recover and then became progressively worse again with the same illness, or if they were in fact reinfected. So I think right now we're relying on just kind of the historical knowledge base that generally speaking, once you've had an infectious disease, you have a baseline immunity for a certain period of time. We definitely don't know at this point what that period of time is, but we expect that there is a period of immunity. But again, this is a novel virus, and we're trying to learn that on the fly as we go.
Okay, thank you. All right, for those of you that have been sending in questions online, thank you for your patience. Just had some that were sent in ahead of time. We wanted to be sure in touch. And we're going to go ahead and start hitting some of those that have been sent online. The first one comes from Matt. He says that they received a supply of N95 masks on them that has a sticker on it saying they're basically outdated and they're not guaranteed to protect them. Still effective if they look like they're in good shape, or should they not be used at all? Does that fall into the something's better than nothing category, or what do you gentlemen think?
Yeah, so NIOSH just recently put out some guidance on expiration dates, and so I think it's important to go ahead and look at the expiration date on those particular N95s that you received. NIOSH recently went through and identified, we had large stores of N95s in the strategic national stockpiles placed around the U.S. that were expired. So they went in and did tests on those N95s to make sure and see, do they have significant degradation or are they still effective? By and large, 95% of those masks that were tested were still effective. So I would go and look at these NIOSH case reports where they looked at shelf life and how far past shelf life those masks were still effective, and see if you're within that range with what was shipped to you.
Okay, and I just saw a follow-up question come as you were speaking there. What about the reuse of N95 masks?
So reuse of N95 masks, in normal times, these are single-use N95 masks. We use them once and we get rid of them. Right now, we've seen numbers of services across the country go into reuse because they're down to their last 500 or 1,000 or 5,000 N95s, and there's no sign of resupply. So there is guidelines out there for extended use and reuse that the CDC has put out. We here at UNMC have started using methods to disinfect those masks for reuse. I think the important thing when we start talking about extended use or reuse, though, from our perspective, is making sure that it's the same mask for the same person. So what's really, this has been explored and investigated a lot. And the one thing that is still uncertain is if you rewear an N95, let's say 2 shifts, 3 shifts, 4 shifts, what we really don't know is what was brought up earlier by Kaylin in terms of seal check. So can you still get a good seal check after you've worn that mask for a full shift or for 2 shifts or for 3? So that's something that you just have to assess. If you're doing reuse, say you're down to your last mask or your last 5, every time you rewear it, making sure you do that seal check and making sure that you've got a good seal.
Okay. And kind of a technical question from Michael. How do you stop eye protection from fogging up? It's a realistic everyday problem for folks. So toss it to either one of you.
I can try to start answer that. So I think like anything, the exhaled breath as it seeps up, especially through a mask, if you're wearing glasses, eye protection, whatnot, that can happen easily. I think going back to Dr. Lowe's point that if you are wearing N95, if you are seeing fogging of your glasses or eye protection, that may be a concern that you don't have an adequate seal on your N95. And so making sure you redo a seal check on that mask because you really should not have any exhaled air from your body going up through the mask and into your eyewear. So that's probably kind of a danger, a caution sign that your mask is not fitting properly if you're getting significant fogging of your eye protection.
Okay, thank you. We're seeing a lot on TV now, in the Omaha area for sure, and then nationwide about the homemade masks that people want to use to help people with. What's their effectiveness? What's their use?
Yeah, so a great question, and something we've been navigating a great deal. The homemade masks are probably the equivalent to a procedure mask. There's a variety of ways to make them and approaches. Our perspective is that an appropriate use of the homemade masks, again, would be the type of mask that we would want to put on a patient to knock down the amount of droplets or aerosol that are being generated by an individual patient. That's the ideal use for those homemade masks. Also, a great option to try to extend your supply or stores of procedure masks that you have. If you have homemade masks that can be provided to the patients, that may allow you to keep procedure masks for your personnel. The distinction about procedure masks is that they have a fluid-resistant barrier on the outside. So you might notice they have a bit of a film to them. What's great about that is it blocks those droplets. So if you have a patient that's coughing and generating aerosol, that procedure mask is gonna block and kind of repel the fluid, which is one of the things that makes it a benefit over a lot of homemade masks.
Okay. How about the homemade hand sanitizer? How effective is that?
So, I haven't tried it myself, but I know a lot of people have been working on it. In fact, I think Nebraska Medicine even put out a how-to on how to make homemade hand sanitizer. The really crucial thing is that to have effective hand sanitizer, it really needs to be 60% alcohol or greater to inactivate this virus.
Okay.
And one thing I would add to that, Doug, I still think the push that good old soap and water and hand washing, vigorous hand washing, is still going to do a lot better than alcohol hand sanitizer. So if you're able to wash your hands, I know EMS, that makes it a little bit more difficult, but if you get to the hospital and you're running low on hand sanitizer, grab some soap, water, would be the best approach.
Okay. Next question comes about decontamination. Some of the steps to take when decontaminating the back of an ambulance correctly, and then it also kind of follows up with the UV lighting and disinfecting and how that works.
Yeah, so in terms of ambulance decontamination, there's a number of kind of tiered steps that it's helpful to kind of do a risk assessment of the latest transport event was and kind of the degree to which you should clean. So what we do in pretty much any operational environment related to COVID is we're trying to identify and regularly clean and disinfect high-touch surfaces. Pretty self-explanatory. Anything that we're touching frequently, doorknobs, equipments, devices, railings, things like that. Those are the things that we're trying to focus in on spot clean just on a regular basis, even if we haven't necessarily identified a high-risk transport for COVID. If we have transported a high-risk transport for COVID and we were performing something like an aerosol generating procedure or moderate to high flow delivery of oxygen, that's a scenario where we're more likely to go in and do a complete holistic wipe down of the back of the ambulance. Really easy to find disinfectants that are effective against COVID-19. The EPA has a definitive list of disinfectants that are good for inactivating COVID-19, and it ranges across the spectrum of of disinfectants from hydrogen peroxide to alcohol, bleach, quaternary ammonium. So that's a great website where if you have a disinfectant that you use for your service, you can go check on that website. The other thing is you can look at the label claims for that disinfectant. A lot of times there will be a label claim for coronaviruses. So the use of UV light and vaporized hydrogen peroxide and some of those other things, we generally use that for a high risk or a regular kind of terminal clean where we've done a lot of runs. We just have a high degree of suspicion for, this squad is contaminated, not necessarily for COVID, but just in general. And we've done a wipe down. We want to completely reset that. So that's an example where we might come in with a UV light or some other, what we refer to as a tertiary clean. We generally like to use anything that is like push button and will take care of an entire environment as a backup cleaning step after we've done that manual cleaning to begin with. The issue with all of those kind of whole area decontaminants is that they generally don't do well when there's organic material. So this could be blood, it could be saliva, it could be dirt. So if you really need to do a basic clean of that environment and then come back in and do a whole environment clean with one of those other things.
Okay, thank you. There's also a question about the home ozone machines. Are those effective in the back of an ambulance at all?
Yeah, so it's really going to come down to the individual ozone generating machine. Ozone to inactivate virus requires really significantly high concentrations, high enough concentrations that it's detrimental to health. So if you have the ability to have an ozone generation device that can generate high enough levels of ozone that it can inactivate the virus, you also have to start implementing kind of gas level PPE to protect yourself from inhaling ozone gas.
Okay. We have a couple of questions. That last one was from Jill. This one's from Kayla. And then we also have Robbie on here that asks kind of the same kind of question. A lot of our folks are transporting anywhere from 1 to 3 hours in the back of an ambulance with potentially COVID-19 patient. Is there any other higher level of protection they should be thinking about for that extended period of time?
So, I mean, certainly N95 to all the previous conversation we've already had would be ideal. The issue with higher level of protection, whether you get into the PAPR or CAPR level protection, which is probably more found on the hospital level, is that those devices tend to be expensive and are a little bit hard to get a hold of right now. And then you have the disposable components or the single-use components as a part of that. So there are higher levels of protection. Whether or not you have access to get to those is going to be a whole other issue. But there certainly are higher levels of protection that would be better for extended use. CAPR device, which is kind of a half hood face mask type device. Those can, we had one of our infectious disease experts overseas wearing one of those for almost a 24-hour period and reported some pretty good comfort with that. So, but again, availability is going to be the thing that you run into on that.
This was back a little bit ago, and I skipped over it, and I meant to come back to it. And Dr. Ernest, I'm going to direct this to you.
Okay.
As you're well aware, and all of us on this particular event are well aware of the graying out of our volunteers. And we have a gentleman who says, I believe he said he was like 65 years old, has AFib, potentially asthma, something like that. Should he bow out for a little while, just in an effort to keep himself safe? That's a tough question.
That is an incredibly difficult question. I oversee several services that are average age of our volunteers is up there, and to be frank, that poses a real question, especially if you're in an area where the volunteer EMS system may be the only medical resource for quite a distance around. And so I think each person has to weigh that individually of your call to serve your community as a volunteer firefighter or EMS professional versus your own personal health. The risk factors that apply to the general public, those that are greater than 60 years of age, other medical comorbidities such as cardiovascular disease, structural lung disease, things of that nature, will put you at risk that if not taking appropriate PPE precautions may put you as a provider at significant risk of death to your own health. So I think that's an individual decision based on your local community and availability of resources. If you're in a volunteer department that has a wide range of members that can help answer the call, maybe sitting out for a little bit until this is passed and trying to let some of the younger folks field that may not be a bad idea. But again, I think that comes down to individual and community situation.
Okay. I'm going to give you a break. I think I might take this one for you. You tell me if I do all right. There's a question about opening up compartments as we're going down the road with the COVID-19 patient in there, and then having to worry about contamination of those items inside there. I guess my thought would be, you know, we've got pediatric jump kits and trauma jump kits. Should we come up with a COVID jump kit so we don't have to get into those compartments, or is it something that we're overthinking and worrying a little bit too much about?
I think any opportunity to reduce contamination of any equipment or personnel should be taken whenever you can. If there's a possibility of taking an old jump bag or something that's been retired from frontline use and putting some basic supplies in there to help care for that patient where you're not having to open up compartments, I think that would be a phenomenal idea if you have that capability.
Okay. We've got a question from Kelly here talking about being pregnant and answering calls and working in a small clinic, and I think that probably would fall into that same advice you gave that last gentleman about being 65. It's going to be a personal decision on whether or not you jump in and do that for now or not.
And as a message, I would say to anyone that if there's any question as to regards to personal health and fitness for duty, a conversation with your primary health care physician is always warranted in those situations to have a real risk assessment and to see whether or not you're fit to do the task at hand. So always I would refer back to the primary care physician.
Okay. Well, we're coming up on about 5 minutes till the hour, and so I've got one more question, and then I'd like to give both of you gentlemen a couple minutes with any final thoughts that you'd like to have. So the last question I'm going to bring in is directed to you, Dr. Lowe. Can people still donate blood right now?
Absolutely. In fact, there's been a fair amount of blood drives lately because it's one of the things with the social distancing and the staying at home. This is one of the things that has suffered as a result of that in terms of there's not as many people going out to donate blood. So that's absolutely something that you can totally still do. We have lots of preventative measures in place to keep that blood supply safe for recipients. Those will all apply to COVID-19 as well.
Okay. Well, I know that there are still a lot of questions up there that we did not get to, and I think that that's a good problem to have. I see we have over 700 people on tonight. That's a fantastic number. I'm very pleased with it. But I would like to go ahead and give our panel a couple of minutes to give us any final thoughts before we end for the night. Dr. Ernest, we'll let you go first this time.
So in closing, first of all, I want to thank everyone for taking the time to do this. I mean, I think it shows a great effort on our state and our volunteer EMS and fire systems out there for you folks being on tonight to try to gain more knowledge about this. As I mentioned in the opening remarks, that reference to the DHHS website has a lot of great resources. The CDC also has some phenomenal pre-hospital resources. What I would suggest is every rescue squad out there, every fire department, take a realistic inventory of where you're at with this process. To make sure to take an inventory of the PPE that you have, to look at your procedures and protocols as to how you would respond to these calls. Again, there's some sample protocols on the DHHS website, and to really take a realistic approach of how you're going to respond to this. And then reaching back out, certainly the regional EMS representatives from DHHS, they're excellent resources, as well as the EMS office. Questions can be fielded there as well. Then also utilizing your EMS medical director. For a lot of agencies, I know sometimes you may have not seen your medical director for some time, but reaching out to that person, they can also serve as a wonderful medical resource to help kind of navigate some of this and get us all through this. So,
okay, Dr. Lowe.
Yeah, so I guess my take-home message to wrap this up is I think it's important to take a deep breath and realize that this is, while this is a pandemic, this is not the end of humanity, right? While we see, pretty shocking and impressive case numbers growing around the world or in New York or in Louisiana, it's important to note that 75 to 80% of cases of COVID are incredibly mild illness where you are perfectly fine to stay at home and get a really mild cold. And then we have that other 15 to 20% that require hospitalization and advanced care. And a lot of those, as Dr. Ernest said, are folks with comorbidities. So I think it's important that we as healthcare providers have a realistic outlook. While the numbers and the reports are really shocking and are out of the ordinary, we're going to get through this. There may be times as we see exponential growth in case numbers that are entering our health system where things get strained and stretched, and of course that's what the news is focusing on and we're hearing a lot of. But what's important for us, especially here in Nebraska where we haven't really seen that exponential growth in cases yet, we may see it, we may not see it, but I think what's most important for the 675 people still online is to take care of yourselves. Self-care and self-monitoring is incredibly important because you guys are the tip of the spear in responding to COVID-19. If you get sick and come to work sick and you spread your illness to others, whether it's COVID or some other coronavirus or a rhinovirus, that's going to impact our ability to respond. So we're telling our teams the same thing, which is, monitor yourself. If you're feeling feverish, take your temperature. Be aware of those things. And then, I think the last kind of point that I really want to drive home, and, I have a really highly respected colleague in Atlanta that I work closely with. And he's signing every one of his emails, "We're in a marathon, not a sprint." So I think it's also important, while many of us are, working really long, crazy days, that self-care piece extends beyond just how am I feeling, do I have any symptoms, but is also, making sure that you're kind of keeping a balance, even though it feels like things are spiraling and we need to do a lot right now. We may be dealing or in this state for a number of weeks, so it's important to see that we may be doing this for a while. Take care of yourselves now.
All right. Well, thank you, both of you gentlemen. Just a couple of quick housekeeping things as we get ready to wrap up. Sometime in the last few minutes or in the next couple minutes, there should be a document come into the comments, and it's going to be for further information on COVID-19. A resource document is going to appear on the stream shortly if it hasn't already. We also place the resource document on our Facebook page and on our website. Our website, for those of you that don't know it already, is unmc.edu/sim-Nebraska, or excuse me, /sim-ne. unmc.edu/sim-ne. As a reminder to the EMS providers that registered for this event to get continuing education, you'll receive an email from Sim Nebraska with information on how to obtain that particular certificate here in the next day or so. I saw some information up there as this was going on about people trying to register during the event. We actually turned the registration off once the event started, and we will be putting up a new registration for people that are watching it either because they missed the beginning of it or because they're watching it at a later date. And speaking of watching a later date, this is being recorded. So once the event is over, we'll go ahead and push all the buttons that need to be pushed to provide that recording. And then Facebook will do its magic, and sometime in the next few hours to minutes, it'll be available for everybody to watch online. Thank you for joining us tonight. I cannot begin to tell you how impressed I was to see 700 and some odd of my brothers and sister EMS professionals, because that is my trade, up on this tonight to find out about what they can do to keep themselves and their communities safe. So thank you very much for taking time out of your busy evenings to do this. For those of you that have ever received emails from me or have ever talked to me and we've ended conversations, I always end my conversations with "be safe," because that's what we need to do. If we're going to be able to respond, we need to keep ourselves safe first. I've fixed that just a little bit. And from now on, my responses to you as we get ready to leave tonight: be safe, be healthy, wear your PPE properly, and wash your hands. Thank you. Good night.